but we are now in our pseudo post or our peri-podium discussion, and I know that some of you may need to run right away, but if you can stay on, all the better. And thank you again, Chantal, for being available much later in your busy day. I know you're always running from early on.
Was Felipa Espada's question answered about the impact of BMI and other factors? It's a question that kept popping up there.
And that was about?
In stage 2 type 1 diabetes patients treated with teplizumab, does BMI or waist circumference affect the duration of diabetes-free survival? She's about to start a trial and wanted to know whether this might be an impact you're thinking about how to run the trial, I think. And Felipa, if you want to extrapolate on that in the chat, please feel free.
I'm sure those data are available. I don't know them. Jay or Chantal?
There's just a very recent publication. Is it Laura? On real world evidence of in diabetology, I think they published it, and they looked at different characteristics of people who were treated. I think it's in diabetology. Let me just quickly look it up.
I think it is.
Yeah.
And while we're in this after party, if people have further conversational topics they want to throw into the chat stream, please feel free to do that. I did remember some questions from the registrants when they registered for the webinar. Why is type 1 diabetes prevention a thing? That's a topic that could be addressed as opposed to treatment or reversal. And can things affect type 1 diabetes like lifestyle modifications or GLP-1s or other topics? So just throwing that into.
I think Chantal made the point that we intervene and are starting at trials in stage 2 and stage 1, which you could argue is prevention. It's certainly prevention of stage 3. And she also pointed out that Annette Ziegler has been leading people who are genetically at risk to have trials early on when they have no other markers, and that would be pure prevention, primary prevention, if you will. So, I think we're moving in all those directions, and I think we're gonna be successful in some of those, and we're gonna see all. My real hope is that every one of those bubbles I showed earlier, we end up achieving success with. Yeah. Because then we'd have many options to choose from, and we'd be able to help all people with diabetes live better lives. And hopefully we'd get some way to pay for it, as was brought up.
Yeah, but Jay, as you know better than anybody else, these prevention trials take a long, long time and huge effort and other resources. And that's the frustrating thing, that to get an event from stage 2 patients to stage 3, or much less from stage 1 to stage 2, that takes a lot of patience to be able to see within a reasonable period of time a meaningful signal.
Can I add, it depends. I mean, again, if regulators want to work with us and accept, for instance, CGM curve changes, where we are really getting better and better at seeing subtle glucose abnormalities. There's also other biomarkers that are linked with speed of progression of beta cell loss. I'm thinking of Guido Sebastiani's microRNAs, proteome signatures, etc., etc. I mean, I am sure when we all work together and we unleash artificial intelligence on all of the data that we have gathered over the years in TEDI and in ODIA and what have you, we will find indicators of disease progression that are allowing us to already after a year or 6 months or whatever say, hey, you know, there's a difference here between those who get an intervention and those who don't. This being said, I am worried that there was also a question on screening for early stage T1D in the general population, how to roll this out. General population don't know a lot about type 1 diabetes. And, you know, to motivate them to get screened is fine. To motivate them to get a confirmation test when they're having a first positive screen is also fine. That's what we learn in Identify. Where things get a bit more tricky is if you now have an individual, general population doesn't know anybody who has type 1 diabetes. And now you ask them, will you take a pill for the rest of your life? Or will you take an injection every 2 weeks or 4 weeks to prevent a disease that you've never experienced? So we as clinicians will have to be very proactive in informing people what is type 1 once they're in this stage, and have people living with the disease with lived experience talk to these individuals why it is so important to keep taking this pill to not get a disease they've never heard of without frightening them. You know, it's really, it's very strange. In Identify, we have more than 120,000 children screened now in Europe, but I'm getting a bit jittery. How will we be able to convince these early stage people to take therapies that are not, insulin?
Yeah, absolutely. And it relates to what Jay said in talking about some kind of major push to cure type 1 diabetes, that there's just not an urgency felt among policymakers to get behind that. There are other competing healthcare issues that are out there. Doing general screening for type 1 diabetes cost, and there is an opportunity cost because there are other conditions that also would benefit from screening. So it's a Gordian knot that's very difficult to untie, and particularly the fact that type 1 diabetes isn't really appreciated as a pain point for 99% of the people living right now. And even though they may know people with type 1 diabetes, they don't see it as a threat to themselves or their kids.
Yeah, but at least I think things are changing. All of us remember 4 or 5 years ago, we had to fight many of our peers, endocrinologists, pediatricians, who were convinced that insulin was enough. That is changing a little bit.
I remember when there was a debate about whether it mattered to control glucose. That was settled starting back in 1993 with the DCCT and then the UKPDS. But there was that day where we had such a primitive appreciation of what was involved with diabetes management.
Well, the other part about that debate was that Marvin Sipperstein would usually be arguing with Joe Williamson. And Marvin Sipperstein, who said glucose control doesn't make a difference, was a much better debater. And he would win on debating points every time, and the audience would go away confused. And so, things have changed a lot. But I want to. You raised something about the need for getting policymakers and a coalition for funding involved. There is the Special Type 1 Diabetes Fund. It's now in its 12th or 13th year or whatever. It helped support TrialNet during my time there, and continues to support things. And it was originally put together as $150 million a year for type 1 diabetes and $150 million a year for diabetes in Native American populations. And it passed because there was a big push from all the diabetes organizations but that's not why it passed. The Senate looked at it and said, yeah, these guys, they're out for their own self-interest. They pushing diabetes, tomorrow it'll be somebody with cancer. But what really convinced Senator Tom Harkin, who sponsored the bill, a former senator from Iowa, was that the AFL-CIO president called him and said, we're behind this.
Wow.
And when he said, AFL-CIO, unions, everybody behind it? Okay, it's not just those with a special interest. That's what made the difference. And he had to partner with Max Baucus, the senator from Montana, who chaired the budget committee, and he won it for Indian health. And that's how it came about, that they put the two things together, type 1 diabetes and Indian health. But
well, that's a great story.
Strange coalition sometimes
Yeah.
that it takes to get these things to happen.
Well, we need to catalyze that. But let me now ask the panelists to look at Steve Carpen's question. Stephen, of course, is at Breakthrough T1D. This is an important question to respond to, looking at the chat here.
While you're reading it, Zan, my naive question was, is beta cell sparing or replacement a registrable endpoint in itself, or does it need to be measured by biomarkers like C-peptide? And Chantal, I guess I was asking, by the time you get to stage 1 or 2, the resolution may not be that great, although you're talking about new generations of diagnostics that can tell us this, and that kind of segues into Stephen's comment about what are better endpoints for prevention and delay trials.
Well, I'll just say morphologic measures will not make it.
No, they're a bit difficult. Yeah. But I mean, that's our handicap. We only have the blood to look at. But I'm a big believer in all of the new technologies. We're just scratching the surface of being able to read immune cells themselves. If we can find signatures of immune cells where we see they are now backing off of the beta cell, they're becoming regulators, they're the attackers are dying, then again these will be important endpoints. For the moment, as I said, I believe the closest to prime time is the CGM measures, where
even in stage 2.
Say again.
Even in stage 2 for dysglycemia.
Correct. Yeah, correct.
And that's what Stephen is asking about.
Yeah.
So again, that's one answer, that CGM, and it's reflecting some impaired glucose tolerance or just impaired glycemia.
Yeah, but we're using 20th century analytics for the moment on our CGM curves. I'm with Greg. I think AI will make a huge difference, not in the next 5 years, but in the next year. Because, I mean, this is simple pattern analysis.
Exactly.
And we can, we can look at it and say, oh, 14% above this and 13% of that. I mean, the computer just looks at it and finds a pattern. So again, in Identify with Minimet, we are in a work package 3. That's what they're doing, not only in stage 2, but also in stage 1, in different tiers of risk. They are asking people to carry sensors. And so they're unleashing machine learning on this. And I'm convinced that they will see subtle changes also in the stage 1. Perhaps not in the higher values, but in the lower values, strangely enough. In the morning, not having lower values is already a very subtle indication that something is going wrong with the beta cell functional.
The problem is the regulators will want some kind of validation of these changes. What do they predict, or do they likely predict in terms of something else? A1C, it's beyond the pale. Onset of the next stage, that's another thing. But that's the kind of data that the regulators will want to validate these surrogates.
Yeah. I
Yeah,
mean, yeah, sorry, go ahead.
I don't know. I was just gonna say, I mean, the biggest challenge is gonna be data sets. That what you're talking about is very small changes in CGM values, and this is one of the lags that we see with the technology. I would argue it's maybe been 5 years that we've had sensors that were accurate enough to give better signal than noise regarding this. So if you try and go back any further than 5 years, the data just isn't there. You've just got noisy sensors where you can't the garbage in, garbage out. And so, there's attempts obviously to CGMIze, the DCCT data and that kind of thing. But, will be able to gather large data sets that can be used for these data-driven models, very quickly, but we won't necessarily be able to gather long data sets until more time. And so we're going to have to be looking, I think, at sooner markers with inference. Otherwise, we haven't had accurate sensors for probably about 5 years only.
Yeah. What about progression of autoantibodies? Is there anything there or anything else that can be measured in the blood? We're talking about for stage 1 and 2.
As said, like the Finns, they're looking at proteome and RNA signatures where they can see in groups correlations with speed of progression. The question will come, will it ever be prime time for a single person, to predict in this person the evolution of C-peptide? I don't know. Again, in groups, microRNA signatures. I'm a believer also in these immune cell signatures, but the question is, for one child, will there be a measure? I don't know.
And we are talking largely about children.
Mm.
And that is a population that we have to take particular care with. We have to be concerned about the potential for safety issues. And that too is a challenge with some of these approaches.
Not wanting to be a pessimist, but Stephen's question is, FDA is inviting discussions. What can we talk to them about? It sounds like we're in very early days for other biomarkers and their validation. So we can start a conversation, but again, as a pessimist,
I think we
20 years
can
from
talk
now.
to them. Yeah, there are some ideas on the table, and we should take advantage of that um, invitation. Colin Diane has some, I think, important proposals that should be considered for early stage type 1. So, let's take advantage of it.
So, Zan, would you explain to me how the device division of the FDA approves glucose sensing to control delivery of insulin, a potentially lethal hormone, lethal drug, and the drug and biologics divisions won't consider CGM as an outcome measure in intervention trials that we're doing? What's the disconnect in the agency?
There has been, Jay, there has been that disconnect. Fortunately, it has changed somewhat. FDA, or my former division, now is accepting CGM measures of hypoglycemia as a potential regulatory endpoint in actual ongoing trials. So there is progress. They're not all the way there. Certainly, there are proposals to use CGM metrics for sort of better measures than A1C, but they too are going to tend to be dampened by the technology. We're not going to see those signals any more than we're going to see them with A1C if everybody is using the technology.
Can I refer to another topic that I saw earlier? I don't know whether we discussed. Monica Wesley asked the question about the new black box for teplizumab and how clinicians should be communicating that to their patients. Zan, I don't know if this is a soft serve for you to share your thoughts about teplizumab, which is of course wonderful to have, but very incomplete in terms of things that we can do for type 1 diabetes patients.
Well, it's great that we've got teplizumab now for stage 2 and stage 3 indications, but let's acknowledge that it's not a perfect intervention. It's got some adversity. It also has some high cost and high procedural cost. You have to go into the clinic to get the injection, and you have to be pre-medicated for it. So it's not a pill, and it's not entirely without some risk. But it's a start, and let's build on it. But it comes back to what was clearly a theme of this discussion, is we need combination products. We need to take an invention from Susan that's going to restore to some extent beta cell function and protect it. It's a no-brainer. We've got to be able to put multiple approved products on the market so that we can use them in combination, like we do in type 2 diabetes. Susan, I wanted to come back to you to ask about any prospects beyond the ones you mentioned of actual therapeutic interventions that you see are promising for inducing neogenesis or beta cell replication. You're on mute.
Unfortunately, I don't think there's been a lot. The field had sort of been put on hold for a long time because there was the sense that there was, that we had to go by through stem cell biology rather than uh, islet growth, whether by replication or neogenesis. So I think the field got really, you couldn't get grants funded for a while, basically. And then I think people have started coming more and more realizing that there's enough evidence that one should study it more. And I think also getting the access more to the human tissue, which is really is showing things quite different than some of the rodent work. So unfortunately, I don't know of a whole lot of other things. I think there are some other groups that are trying to do some screens, but I don't know of any others that really have gotten there yet.
Well, keep going. It's such an important field, and it's regrettable that the progress has been dampened by lack of resources.
Right. No, I agree, but it's exciting that it's finally, I think people are paying more attention to it.
Zan, we're coming down to the last couple of minutes of the half-hour after party. I have a question for the panel. Maybe you are also caught up on the field and the other disciplines of the fellow panelists, but I'm curious what questions you have of the other panelists based on what was discussed. Maybe you had some questions, or maybe, but we haven't had a chance to have that. We in the audience would be very interested to watch the tennis match, if you will, or the soccer dribbling of experts. What interests them, and where how they're reacting to the things they hear from each other.
Yeah, well,
My one conclusion that I continue to make after hearing everybody speak is we're going to need combination approaches.
Yeah.
A single intervention will not do it, and we have to consider multiple pathways. I was fortunate in 2012 to get an IND for a 4-drug combination to try to use in new onset type 1 diabetes. You're trying to arrest the adaptive immune response, to diminish the innate immune response, to stimulate the regulatory immune response, and to improve beta cell health. And the FDA gave me the IND. and the ethics committee approved the study. And I had 11 centers who were signed up willing to do it. And I couldn't get the drug. I had JDRF and DRIF each give me $3 million toward the study. And I couldn't get any of the companies to give me the drugs because they were all afraid that somebody else's drug would cause a black box warning on their drug, and they didn't want to contribute to that kind of thing. And it was a very frustrating, experience. And maybe I was too ambitious putting 4 drugs together. Nowadays, I'm only trying to do 2 at a time, and then can add as we go on. But I think that, you know, we need to get cooperation from industry. And I think one of the things about the approval of teplizumab has done is it's gotten more companies interested in the space, because they do see that it is possible to get disease modifying therapies approved around the world. And you know, that will help us advance things, and hopefully will allow us to do combination therapies more and more.
That is a good thing. And it also will help to have these different therapies approved so they can more readily be used in combination therapy trials. To do them as multiple unapproved agents under IND is going to be more cumbersome. And so
well, 3 of the 4 drugs were approved. I couldn't get the company
for other indications, not for
other indications.
Yeah. Well, that's one of our many challenges. We haven't solved them all today. In fact, I would say we've only made a dent in understanding them, but it's been such a great discussion. I can't thank all of you enough, and particularly Jay and Chantal. I want to come back to you about a project we're working on.
You keep coming up with all these projects for Chantal and me to work on with you, but we love it because we agree with the sentiment completely.
Well, it's an honor to be saddling up with you. So I guess we'll say goodbye to our audience and to our panel, and stay tuned for the next time that we talk about type 1 diabetes, other important public health issues. Thank you all.
Bye-bye.
Bye.
Bye.